Hi, this is Chapter 19 on Oncology Social Work. And according to Gellert and Brown, oncology social work is a specialization in social work that addresses the psychosocial responses and needs of individuals and families affected by cancer. And social workers use multi-systemic and holistic practice, research, education, and advocacy to add to the knowledge base and the provision of care to cancer patients and their families. And just a little background on what cancer actually is. It is characterized by uncontrollable growth of abnormal cells in the body. And it's estimated that over an average American lifespan, 44% of men and 38% of women will develop some form of cancer. And there's approximately 1.5 million cases diagnosed each year. And of course, these cases vary by gender, race, and ethnicity, but the most common are non-Hodgkin's lymphoma, melanoma, prostate, breast, lung, colon, rectum, uterus, bladder, kidney, and ovary. And it's important to note that cancer cells begin to damage genetic material that leads to the growth of abnormal cells, as I had mentioned before. And this is because of the failure to repair the mutations, and these cells act in a disorganized manner. They divide more rapidly than regular healthy cells, and they lack the programming to complete their genetically assigned functions. And cancer cells form tumors. So cancer is caused by a number of different factors, most or mainly by interactions among genetic, environmental, behavioral activities, and social experiences. And cancer caused by genetic damage or mutation, it can occur randomly or sporadically, and others tend to be passed from generation to generation, so they're generational. And another interaction that can cause cancer could be environmental influences, such as exposure to toxic chemicals, air pollutants, viruses, or sunlight and UV rays. Also, behavioral patterns are another cause, which could be the use of alcohol or tobacco, obesity or dietary wellness habits or lack thereof, sexual and reproductive behaviors. And finally, social circumstances also contribute to cancer sometimes. For example, poverty or racial disparities in treatment, or the lack of access to adequate housing or nutrition, clean air, education, or health care, or potentially even preventative screening. These can all contribute to cancer expression, treatment response, and mortality. It's important to note that cancer represents 25% of all deaths, and approximately 570,000 Americans die each year from cancer. But we should also note that this number has decreased since the 90s because of some preventative efforts and improved early screenings, as well as treatment advances. So we are making progress, and hopefully that will continue to happen. So just a little bit about cancer treatments. Most of cancer treatments are designed to eliminate or shrink tumors and to prevent cancer from spreading or reoccurring. Surgery is used for prevention, diagnosis, and treatment of cancer. And it's also important to note, too, before we get into the other treatments, that treatment is basically decided primarily on the type and the invasiveness of the disease by oncologists. Also, its stage of development is considered. And some other important considerations could be the effectiveness of a particular treatment, the overall health of the individual, and the short-term and long-term side effects of treatments, which may vary across different groups of people. And finally, financial considerations have to be taken into account. For instance, whether the patient has insurance or is able to pay out of pocket. So the other types of treatments are chemotherapy, which are medications that attack cancer cells throughout the body, and radiation, which is ionizing radiation to precisely treat hard-to-reach cells in hard-to-reach places. And it's important to note as well that surgery is usually used in combination with other treatment modalities, for instance, chemotherapy and radiation. And another option is alternative and complementary treatment. It's estimated that 53 to 68% of all adults in the U.S. have reported using an alternative or complementary treatment. And this can include prayer or spirituality, naturopathic supplements, relaxation, breathing exercises, yoga, chiropractic care, those types of things. So a brief history of psychosocial oncology. There was really little known about cancer until the 20th century, and people diagnosed often experienced really bad pain, incapacitation, disfigurement, smelling tumors, isolation, and a loss of self-worth. So it was really because little was known about the disease. So there was really nothing that could be done until really the late 19th century when anesthesia was introduced, and then surgery was able to be used more frequently. And then in the 1920s, radiation was introduced, which helped to effectively shrink some tumors and was used in conjunction with surgery. And then as we became more knowledgeable about cancer, the National Cancer Institute was formed in 1937. And finally, in 1970, Richard Nixon pronounced a war on cancer, and then there were cancer centers that were popping up around the country for research and clinical practice, which greatly expanded the knowledge base as well. And after the 60s and 70s, it's important to note that there were more cancer survivors because of the advancement in treatment and research and clinical practice. Cancer actually became known as a chronic episodic illness rather than a terminal condition after that time period. And since the earlier 20th century, social workers have helped the oncology profession with person-environment perspective and offering clinical advice and education and many other factors and supports. So the psychosocial impact on cancer patients can be emotionally devastating and a life-altering experience, as quoted by Gellert and Brown. And psychosocial issues could include an undermining sense of self and self-worth, provoking fears and anxieties. It can test coping mechanisms, values, and social supports. And also, those with cancer oftentimes have higher rates of mental illness. It has been reported that higher optimism has led to less emotional distress and higher levels of social support as well, less distress, and also having a higher sense of spiritual or religious affiliation was associated with less emotional distress. So kind of just continued on the psychosocial impact. Cancer affects the whole family system. It can disrupt family and social roles, causing emotional upheaval and requiring changes really in all family members so they can manage the disease and maintain normal functioning. And families have to adapt to the illness through complex and often unconscious changes in structures. Also, rules and communications with one another have to be adapted to support this illness. And it's noted that the family is usually the main caregiver. So, with the family being the main caregiver, there really needs to be a high level of communication, flexibility, mutuality, cohesion, and just an understanding of the illness variables, including the disease course and the anticipated outcome and the patient's level of functioning. And genetic testing and reproductive decision making is also part of the psychosocial impact because 5 to 15% of all cancers are genetic. So this is a concern for some people. And people can use blood tests to identify presence of mutations, which can cause further stress if mutations are tested positive. It can also provide information about the bloodline and inform family planning. And then another impact of psychosocial, or the role of psychosocial, is the cancer over the life course. So age determines the psychosocial impact. For example, the psychosocial impact of a child is going to be much different than for an adult. A child might have, a very different interpretation or experience of the illness and even the treatment process according to their cognitive and developmental capacities. So it can impede the resolution of normal developmental tasks, such as individuation from caregivers, identity development, and building intimate friendships. And then older adults, kind of on the other end of the spectrum, account for 77% of new cancer cases, and they, of course, are going to have a different experience with it. They're more likely to have a concurrent chronic illness, such as disease or cardiovascular disease, which can further their psychosocial distress. And chronic illness later in life, according to our text, is associated with increased pain, depression, and mortality, and with a lessened quality of life. And this is a very significant time for older adults, a time of transition, including retirement or changing of family roles, and even deaths of loved ones and declining health and independence, reduction of. And older patients often have concerns of the process of dying and a loss of autonomy and control. And they, are worried about becoming a burden on family members. So they have a lot of psychosocial issues that they're dealing with. And then finally, cancer survivorship. Often when survivors of cancer are living longer, they have to deal with long-term effects that cause emotional distress, functional limitations, and other chronic health problems. And this can include anywhere from like skin rashes or dry skin to fluid retention in the arms or the legs. And younger survivors often have different psychosocial impacts, such as needing to be reintegrated with their peer groups, worrying about reoccurrence, might have earlier rates of mortality, and potentially might have concerns about reproduction and sexual function. So oncology social work, as defined by the Association of Oncology Social Work, has these standards of practice. The first one is clinical practice via psychosocial services and programs, and that's what we'll focus on the most, but I'll read through the rest now. Also, services to institutions and agencies to increase their knowledge of the psychosocial, social, cultural, and spiritual factors that impact cancer survivors or cancer patients. And the third one is community education, consultation, research, and volunteering. Again, to utilize, promote, or strengthen community services and programs and resources available to cancer patients or survivors. And then the final one is services to the profession to support future oncology social workers, potentially through clinical supervision or evaluation and training and education. So, kind of back to the first one, clinical practice via psychosocial services and programs. Social workers in the oncology field have to conduct comprehensive assessments, biopsychosocial assessments, of course. They have to assess coping strategies with patients and families and help them develop adaptive coping strategies. They help patients and families navigate systems. They also help to provide resources and services to improve quality of care. They can teach strategies to manage and reduce symptoms and side effects. And they can also provide supportive and therapeutic interventions to individuals, groups, and families to address all of the emotional distress that accompanies this illness. They can also provide family conferences to increase communication with the family unit, and they really emphasize the family unit as a basis of care. And there's quite a few theoretical frameworks that are used in oncology social work, particularly in the clinical practice, and these can include psychosocial oncology, of course, attachment and loss, stress and coping models, family systems, ecosystems perspective, person and environment, child and adult development, and narrative and meaning making. And of course, oncology social workers practice the ethics and values that are present in the National Association of Social Workers, which promote service to clients, individual dignity and self-determination, social justice, and the importance of relationships, as well as integrity and professional conduct. And also, social workers should have knowledge about cancer and oncology, the types of cancer, the symptoms, treatment protocols, medical procedures, etc. And they also want to have this knowledge to help track a patient's changing medical situation and assess the extent to which patients and families understand the disease. And then, as we mentioned before, they really want to help families and patients navigate the complex systems. And then another important aspect to the clinical practice is the cultural competency and advocacy. Social workers in oncology have to be able to practice with a variety of people from cultural, ethnic, racial, socioeconomic, and religious variety of backgrounds to provide culturally sensitive assessment, care planning, and psychosocial support services. And finally, through the clinical practice, oncology social workers need to communicate and be with the patients and their families through the long-term period of the cancer's longevity, whether it ends in palliative care, end-of-life care, or survivorship. And finally, oncology social workers should research on evidence-based practices to improve psychosocial care. And this, to improve, could be through engaging in research that addresses the cancer experience for patients and their families across the entire cancer care continuum. And some of the challenges to oncology social work are that healthcare providers don't necessarily always address psychosocial issues. And often emotional, psychological, behavioral, and spiritual needs are not met. Finally, social workers are not always a part of the oncology team. But luckily, through the developments in cancer care, they have supported the use of social workers to develop innovative interventions to meet the needs of their clients. So in conclusion, social workers in oncology contribute significantly to the provision of high-quality, family-centered biopsychosocial care for cancer patients and their families in a wide variety of settings.